I will begin with panel 1 now. Diagnosis, research, and recovery. So what I'm going to do today is tell a brief story about how I met each of the speakers today and why I asked them to join us. Let me begin with my first introduction. In February this year, I attended the Women's Leadership Conference right here in Bellevue, and I saw that Dr. Consorti was a speaker. I was already formulating in my mind that I wanted to invite local and national surgeons to be speakers at the event today. So when she stepped off the stage, I went down to greet her. And I asked her, I said, Dr. Consorti, I'm formulating a symposium. Would you be willing to talk at the symposium? Without hesitation. She said, yes. And so not only did she say that so quickly, she also put me in touch with her team here at Overlake that provided this beautiful auditorium today. So I am really grateful to you, Dr. Consorti. She is the medical director at Overlake Cancer Center, a breast surgeon, has over 30 years of experience in the medical field. And I might share with our two out-of-state Texas surgeons that she did training at the University of Texas Medical School at Houston and at MD Anderson Cancer Center, Department of Surgery. Please welcome to the podium, Dr. Eileen Consorti.
All right. Good morning, everybody. I really want to thank Terry Kuti and the DiepCFoundation for inviting me to speak. This talk summarizes what I do every day in my profession as a surgical oncologist. So it really hits home. I am also a cancer survivor, breast cancer survivor, I have to say. Empowering patients, making informed choices about their cancer treatment, surgical options, and also finding out what resources are available to them in the community. These are all really important points. So this is my talk, empowering patients to make informed choices about their cancer treatment care plans. There's many ways that patients arrive at a breast cancer diagnosis. There's self-palpation, where they're in the shower or lying flat and feel a lump, or where they go to their clinicians and the clinicians do an exam and feel a breast mass as well. They could be minding their own business, undergoing their routine screening mammograms when an abnormality gets picked up, or having an ultrasound because they were told by the media, hey, your breasts are a little dense, maybe you need an ultrasound on top of that mammogram, and the ultrasound detects a mass. But the real question, and I pose this to Dr. Chung, who I met today, my basic science research breast cancer friend at Fred Hutch, the real question is when is there going to be that blood test, right? When can we go and get some blood drawn and say, hey, you've got some circulating tumor cells in your bloodstream. You might want to really get that breast MRI. It might be time. So that's the question. So right now, the CTC or the circulating tumor cell assays are being used in patients who've completed their treatment. Kind of as a guide, you may have seen it on Facebook, Signatera and Natera, where they look for circulating tumor cells, they get that baseline, and then they follow them out to see if there's a spike in those. But I know, and I'm hopeful that within the next couple of years, we are going to get to that blood test. Okay, now this is another dilemma. Okay, I just have to put in my 2 cents for the Commission on Cancer. What is the breast cancer timeline? And Dr. Chrysopoulos, I'm sure you have your issues with this timeline, right? Everybody's got issues with this timeline. Yes, exactly. We have this long thing. So just to let everybody in the audience know, the Commission on Cancer gives a 60-day timeline from the time you have a needle biopsy that shows cancer cells to the time you go to that first step of treatment, whether it's chemo, immunotherapy, or surgery. You got the 60-day window. It's a quality metric. There have been issues with this 60-day metric. I have to say, even before COVID hit, even before we weren't imaging women for an extended period of time. And the problem, I have to say, I think, is with the MRI biopsies. And it looks like it's a trend going across the nation. So we have a patient that comes in, has a new diagnosis, maybe has dense breast tissue. As a clinician, I'm like, you might want to think about an MRI. MRIs are going to find additional lesions about 17% of the time. Let's get a good roadmap before we take you to surgery. And so then that's the dilemma. That's the delay, the MRI biopsy time slots. Other issues, radiology technologists are in short supply. RNs are in short supply. So we all struggle with that 60-day timeline. Hopefully, I think that Commission on Cancer is going to take off the 60-day quality metric for hitting surgery, but still is going to retain it for getting chemo or immunotherapy if they're going to get that as their first step of treatment. So when you do get that diagnosis and you're frustrated and say, hey, I just want this tumor, get it out of my body now. These are the issues that we're facing as clinicians in the institutions where we practice. And I know it's a nationwide issue. Okay, how to navigate through your treatment. It begins and it ends with the nurse navigation, I have to say. I've been in charge for breast centers down in the Bay, now up at Overlake for the last 4 years. And I have to say, patient navigation is key. You absolutely need that patient navigator. If anybody in the audience has a new diagnosis, use the nurse navigator, call her. She can set up your appointments for you. She can help you navigate to social work if you don't know what your community resources are. Breast cancer should be a team, including the plastic surgeons, and we know that, and we do send those referrals up front. So, I mean, this is the navigation network. It does take a village. But if you do get treated for your breast cancer, make sure you're going to an institution that you feel comfortable can meet your community needs, your family needs, let you know what resources are available, nutritionists, physical therapists, massage therapists, integrative oncology is on the forefront now. So know that, because it's not about at this point just saving your life. It's what is your life going to look like after you finish your treatment? How are you going to get back on that bike? Or how are you going to function taking care of those kids at home? And that's where we're at this point. And the Cancer Network can help you with the answers to those questions. So make sure you use it. And then we go there. All right, breast imaging. Most people that come in with a palpable lump, the first thing the clinician's going to want to order is diagnostic imaging. So that's comprised of a diagnostic mammogram and an ultrasound. If there's any density at all, the clinician's going to order a breast MRI. And again, as I mentioned, breast MRIs pick up additional lesions about 17% of the time. It's worth seeing because when we do get those women to have their MRIs before they go to surgery, we're not seeing the recurrence rates we used to see way back when, because I am old. But breast MRIs, I think, have made a difference finding that. Staging scans, people come in with a very small tumor saying, hey, I want to get scanned from head to toe. I want to make sure there's no cancer in any other part of my body. And then I have to carefully explain, well, insurance will only allow a PET scan if you have a stage 3 or above tumor. But we can do an MRI, and MRI is going to look at not just at the breast, but it'll look at the lungs, it'll look at the liver, it'll look at the ribs, and those are all the places where cancer would go to. Okay, there's 3 treatment modalities for breast cancer: local treatment, plastic surgery, regular surgery, radiation therapy. And what these clinicians do is either reconstruct the breast or treat the breast to remove the cancer, treat the tumor bed so the cancer won't return to that site. There's systemic treatment, as in medical oncology prescribed, what the American public has read as hormone therapy, which is really not hormone therapy, it's anti-hormone therapy, but it's got sold to the American women as hormone therapy, which is the same as endocrine therapy. There's chemotherapy, which are drugs that go either in the vein or pills that you take to help eliminate cancer cells that are actively dividing. There's immunotherapy that targets, and Dr. Chung will talk about that, but targets specific proteins on those tumor cells to help eliminate those tumor cells, such as in the silver bullet that we were all promised and we're still waiting in some instances for. And then lastly, treatment sequencing. Do you have a new diagnosis? Do you get surgery first? Is a clinician recommending that you see the medical oncologist for chemo or immunotherapy before surgery, and then followed by surgery, and then followed by radiation? So I'm a surgical oncologist and I have this dialogue, I have to say at least 7 to 10 times a day because we have a really busy breast cancer practice. Washington State has the 5th highest rate of breast cancer out of all the states. And, we talk about the numbers and it's just astronomical. Yeah, my fellow colleague and I treat over 370 women a year with new diagnoses of breast cancer. So we're really, really busy. And this is the conversation I have all week long. Lumpectomy versus mastectomy. How do you decide? My job is to talk about relevant clinical trials, the outcomes of those clinical trials, how big their tumor is, what their MRI looks like. Are they a candidate for breast conservation? Is their anxiety off the chart? Do they have a strong family history? Would they just feel better at this point getting the breasts removed? And we have those dialogues. This is just a pictorial of a mastectomy, which means removing the breast tissue. Now, the breast tissue goes all the way up to the clavicle, sometimes your collarbone, all the way out to your armpits, kind of down where you start feeling your ribs down on your upper abdominal wall. So mastectomy is removing that breast tissue. When I first started in practice, and I am old, I'm going to retire in 2 months. I have to say, this is my last talk. Yay! Yes, I think that number. And so when I first started, we did modified radicals. Sentinel nodes hadn't come into being until the mid 1990s to late 1990s. And I did sentinel nodes, I think the first ones at University of Minnesota. And I was at MD Anderson. They shipped in the sentinel node guru to go from room to room and teach all the clinicians how to do sentinel nodes. That's how old I am. Dr. Giuliano got flown into Houston to show the MD Anderson people how to do it. So a modified radical, it's removing the breast, but it was also removing at least 15 lymph nodes from the axilla. And needless to say, it contributed to a lot of arm edema. And if I don't ever see that surgery again, I'll be happy. But unfortunately, there's still some women that need quite a few nodes removed because they're positive for cancer. The plastic surgeons are really going to go in depth about all the flaps. And so I'm going to breeze through this, but skin sparing mastectomies involves removing the breast, but also the nipple. Not everybody can get a nipple sparing mastectomy due to how the breasts drop. And these guys will talk about that. But if they're not a candidate to preserve the nipple, skin sparing mastectomy is usually done with reconstruction, either flaps, and that they'll be in detail about the flaps, or putting in implants. Nipple sparing involves preserving the nipple. These incisions off to the right, I meant really technically when we do nipple sparing now, we just either do incisions kind of at the base of the breast called IMC incisions, or we do lower vertical. So we don't really do that assortment of. When do we talk to women and say, hey, you might want to think about a mastectomy? This is a patient, young premenopausal woman. She only had an isolated little tumor that you could see on the mammogram and the ultrasound. It was small. It was like 1.5 centimeters. I'm like, your breasts are a little dense, get an MRI. And the MRI, the right breast is over towards me, left is over towards the far wall. And as you can see, the right breast is full of bright lights, and that indicates DCIS and tumor. And so obviously not a candidate for just doing a lumpectomy. I mean, she had tumor all throughout that breast. Lumpectomy. And again, this slide's a little outdated because we don't make those incisions typically. But lumpectomy, partial mastectomy, quadrantectomy, segmentectomy, it all means basically we're going to remove the tumor, remove it with a rim of healthy breast tissue around it. And also sample the lymph nodes if it's invasive disease. If it's ductal carcinoma in situ, which are tumor cells confined within the milk ducts, we're just going to do a lumpectomy. Our incisions are pretty cosmetic now. If the tumors are up kind of towards the armpit area, we do everything through single incisions, do the sentinel nodes through those incisions. And then we also do tissue rearrangement or oncoplastic repair so the women don't end up having divots there, kind of deformities of the breast. How successful? And I think ours is better than 80 to 90% of the time we're able to get all the tumor. We do shave margins. I started doing that after I had a long talk with Armando Giuliani one day. He's like, try shave margins. So if you could imagine a tumor in the breast suspended within a box, we take the tumor out and then we just do little shaves all around those 6 edges of the box and send those off individually to pathology. And that gives the pathologist a lot more comfort in calling a margin negative, which is the bane of the surgical oncologists. You know, we do not want to see positive margins. Localization techniques. Oh, look, it pops up. So there's different ways you can localize tumor. When people got their biopsies done, the radiologist put little clips, teeny tiny little clips in the breast tissue. And I can't see those clips. I can't feel those clips. And the goal, of course, is to get the tumor out that has a clip in the center of the tumor. There's different ways to localize. Here at Overlake, we primarily do Savvy Scout localizations. There is a little photo that has a Savvy Scout that somehow didn't end up on the slide. But most of our localizations are done via Savvy Scout, where the radiologist a few days before surgery puts an additional little clip via a needle insertion into the tumor. It has little antennae at either end, and I use this magic wand or probe that can detect that clip, and that really helps eliminate the possibility of a positive margin. This little X-ray is wire localization. We typically only do wire localizations if they have an extensive area of what's called calcifications on their mammogram that could indicate a wide area of ductal carcinoma in situ. And we have the radiologist do a bracketing where they put a wire and create like this runway to remove the DCIS within the breast. We orient the specimens, putting little clips on there that show, you know, which margins, you know, how the tumor was oriented within the breast tissue itself. So why do we orient a specimen and what's a margin? We orient the specimen to let the pathologist know how the tumor sat within the breast tissue. Because if the edge of the specimen has tumor coming up, right up to that edge, the pathologist we're depending on to let us know what edge that is. So we take margin orientation very seriously. We orient it with what's called charms or ink it. We vary on that. I came from MD Anderson. They all do suture orientation, which is called LSD. I don't know if they got it from LSD in Chicago but that's how the specimens were oriented with sutures. Since I got here, they were like, oh no, we don't do suture orientation. We do Savvy Scout or the charms. So I got addicted to the charms. So there you go. Margin, what is a margin? So for invasive disease, what we want to see is no tumor cells coming up to any of the edges of the specimen. And that's a negative margin for invasive. For DCIS or the tumor cells within the milk duct, it's a little bit different. We want 2 millimeter margins, and that's a negative margin. And then lymph nodes, how do we check them now? If you have invasive disease, the recommendations, unless you're over the age of 70 with a really low-grade tumor, is to do a sentinel node biopsy. For the women over 70 with low-grade tumors now, sometimes we put it into a nomogram to calculate out the risk of them having a sentinel node. If it's low risk, then we don't even recommend sentinel nodes for those patients. But the sentinel node biopsy, again, pioneered Armando Giuliani in the 1990s. And what they did is injected technetium, which is a low-level radioactive emitter with blue dye. They inject it into the breast. It migrates to, I always call them the mother nodes, or the first nodes that see the lymphatic drainage of the breast. So that the involved sentinel nodes will either turn blue or have radioactive or both. And then I remove those nodes and send them up to pathology to make sure there's no isolated tumor cells or tumor clusters or actual occult disease in those nodes. So that's a sentinel node biopsy. And again, that's just showing the injection of the blue dye in the node. The nodes are taken out through a small little incision. The national average, I think, for sentinel nodes per patient is 3. I always tell patients, look, you can have 1 node, you can have 8 nodes. It just depends on how your body makes those sentinel nodes. The other thing to note is after you've had a sentinel node biopsy, you will reform sentinel nodes, a year, 2 years, 3 years after the surgery. So it is possible to reform those sentinel nodes. An axillary node dissection, that's removing, I would say, 15 upwards of lymph nodes in set anatomical boundaries under your armpit. The risk of axillary node dissections is about 20% risk of lymphedema. Are we still doing axillary node dissections? Yeah, unfortunately, we still are. We have patients that have 2, 3, 4 nodes with really, large tumor deposits in those nodes, and we're going to have to recommend still removing those nodes. I'd like to just send them to the radiation oncologist and say, you deal, but the radiation oncologists are like, that question hasn't been answered with clinical trial yet, we're holding off. Go ahead and take out more nodes. We send all those patients, if we know we're going to take nodes, out to the physical therapist ahead of time, get fitted for arm sleeves, do a lot of lymphedema prevention. Yeah. Question: if a patient needs radiation therapy following surgery, who's not a candidate for a lumpectomy? If they've had prior radiation to the chest wall, sometimes that sets up a lot of cosmetic deformity. And if you add more radiation on top of that, really sets up a lot of scar tissue in that breast, and for a lot of women, chronic pain. If breast cancer is diagnosed early in pregnancy, and that's probably debatable, maybe not a lumpectomy. However, we have had patients that have had lumpectomies during pregnancy, their second trimester, and then just followed up with radiation after they delivered. Diffuse or widespread disease. Other contraindications: lupus, scleroderma, if somebody's had a diagnosis of a connective tissue disease. There is a genetic mutation. I had a patient the other day that had an ATM mutation, which kind of precludes radiation, and she wanted to opt for bilateral mastectomies anyway because of her family history. I'm like, okay with that. Large tumor in a small breast, unable to chase or get negative margins, especially in cases of DCIS. And reconstruction, I'm not going to belabor this, just shows expander placement. We do a lot of delayed reconstruction in the state of Washington. I don't know if you guys are aware of that, but yeah, so expanders are usually placed, and these are all the flaps, either deep flap or latissimus flap. Oncoplastic breast surgery, basically trying to get cosmetic bilaterality in those breasts, make them, I would say, even Steven, which can be a headache or not, usually involves some reconstruction on the opposite breast. But that's an example of oncoplastic. We do breast flaps where we take a person's own breast tissue and create a flap so they don't end up having a divot or a cosmetic deformity in the same breast again. So which is better, mastectomy or lumpectomy? For an average risk woman, and this is a woman with no genetic mutations, there's really no difference in overall survival, mastectomy versus lumpectomy. That's been borne out by multiple clinical trials. The Milan trial, again, I was at, I think, the American Society of Breast Surgeon meeting when the Italians presented their 20-year follow-up and showed, look, really, depending on what they did, there's no difference in overall survival for those women. And then, of course, MD Anderson's multi-center trial in the 1990s confirmed that for the NSA-BPV6 trial. And then finally, the Swedes, I don't know if anybody followed that Swedish paper, they actually showed a little bit overall survival advantage with the lumpectomy radiation arm. And they think that that's because some of the patients that had mastectomies probably needed some radiation and didn't get it because of the way the trial was constructed. Okay, and what's the risk that cancer will recur? I have to say, even in the arms of mastectomy, I've had a couple women come in that I did not do surgery on, but came to come visit me, 5, 6 years after their mastectomy and did have tumor recurrence. It seems like where the tumor can recur is up by the armpit area, up on the high side and that upper outer quadrant, because not all the breast tissue, even in the best of hands, even though we like to think we're taking out all the breast tissue, not all the breast tissue can get removed. And that breast tissue that's left behind can transform into cancerous tissue. Lumpectomy alone, and I have to say, recurrence rates high, 30 to 40%. The addition of radiation drops it by about 20%. And then endocrine therapy can drop it all the way down to 3 to 4%. So I meant there's a 1% absolute difference. But I have to say, anxiety, I have to say, plays a role. And if I have a woman and she's like, I've got a family history, I'm like, hey, I've genetically tested you, you're negative. They're like, forget it. I want bilateral mastectomies. And I'm like, it's your body, it's your choice. Yes, go see the plastic surgeon. Here's his number, here's his card. Go see him. So contralateral prophylactic mastectomy, who should consider it? The genetically positive, for sure. We have those dialogues. And I want to say genetic positive with a risk probably greater than 30%, because I know some of the genetic mutations, the risk is not as high. History of mantle cell radiation to the chest before the age of 30. And again, no benefit for the average risk women, but it does alleviate. And I have to say, I've had patients, they go bilateral mastectomies, hands down. They never regretted that decision. Never. I've never had a woman come back and say, if I might have done things differently. I haven't seen that. And then after treatment surveillance, what can we expect? If you get breast conservation, annual mammogram, if there's any kind of density, MRI, I would supplement with at 6-month intervals, clinical exam. And then that's it.